Thank you so much, Sam, for this kind introduction. So today I'm presenting the data from my recent paper that was published in Hypertension Journal as said by Sam. And yeah, I'll go straight to my presentation. Right. So starting with the global statistics of the stroke. Stroke affects millions of people around the world, many of whom die, and many remain with the permanent disability, which increases the socioeconomic burden. Pre-existing hypertension is the biggest risk factor for the stroke, as we all know, which accounts more than 50% of the total stroke occurrence. Now, if you talk about New Zealand, it is second largest cause of death. 9,000 adults die every year from the stroke. From these 9,000 people, generally 10% of the death occurs in those under the 65 years of age. Now, as we know the statistic, we need to understand how the stroke happens. So what is stroke? There are two types of stroke. The one is hemorrhagic stroke. It is defined as when one of the cerebral artery ruptures and the blood spreads into the brain tissue, causes the hemorrhagic stroke. It accounts for approximately 20% of the total stroke statistics. Second, ischemic stroke, as you can see in a figure now, that when thrombi or emboli originating from the outside of the brain travel to and block one of the cerebral arteries and occlude the blood flow to the downstream brain area, causes ischemia or ischemic stroke. It accounts approximately 80% of the total stroke, and that is why we are more interested into the ischemic stroke. And the interesting fact is that clinically, more than 80% of the stroke patients produce the post-stroke hypertensive response. We think that the brain drives this response. As you can see that after stroke, the post-stroke hypertension appear on your screen, and the brain drives this response to ensure that it receives sufficient oxygen and nutrient supply to the affected area. Post-stroke blood pressure has been shown to remain elevated for several days to weeks before it's returned to the or returning to the baseline level. Now, this event raised multiple questions. Why and how this response developed? What are the triggering mechanism behind this response? Is the post-stroke hypertension a beneficial response which aids the blood flow to the brain area? Should post-stroke hypertension be treated if the blood pressure reaches to the dangerous level? If stroke patient has undiagnosed hypertension, blood pressure may be overtreated by the clinicians. Is that really dangerous? And fifth is whether pre-stroke blood pressure treatment can be re-established in acute period of stroke. However, these questions are still not completely answered by the researchers or clinicians, and even existing international stroke guidelines do not define the recommended blood pressure level or set blood pressure levels after stroke or within the acute period of stroke. So there is urgent need to improve our understanding of the post-stroke hypertension to improve the patient outcomes after they have a stroke. Now, to understand this response, we have to consider the potential clinical scenarios in the stroke patients. We found that several hidden or unaddressed issues from the clinical studies which already been published, which are likely to cause the higher mortality in stroke patients. The first one is hypertensive patients. Older patients have degraded vasculature, as we all know, and the sudden increase in the blood pressure can lead to the secondary complications such as the hemorrhage. Second, undiagnosed hypertension. So generally 15% of the population do not know that their blood pressure is high. Undiagnosed hypertension, it's a serious issue because if it is present into the stroke patients, technically we cannot identify these patients at the time of hospitalization. And maybe clinicians may mistakenly overtreat the post-stroke hypertension. So lowering the blood pressure to below their true baseline level or pre-stroke baseline level may be dangerous or not. Third is the treated hypertension. So if patient treated with antihypertensive medication before they had a stroke, they are still at risk of having a stroke in future. It is still unclear how the blood pressure should be controlled in these patients during the acute stroke period or acute stroke period. Now, so we identify these issues in the clinical world and design our preclinical study in rats, as you can see in the picture, with one hypothesis that post-stroke hypertension is a beneficial response. If post-stroke hypertension is beneficial, then no treatment is required, which identifies group as uncontrolled. So we didn't give a treatment in a group where we named as a uncontrolled group in our group nomenclature. However, since sudden increase in a pressure may increase the chance of secondary complications, as I said, as a hemorrhage or some other complications, which promotes to control the blood pressure. So post-stroke hypertension should be controlled. So I tried to control the blood pressure after stroke relative to their pre-stroke baseline level. Now, moving towards methodology section. So to induce the stroke, I used the middle cerebral artery occlusion model in our study. As you can see in the middle figure, I inserted the filament from CCA into, or CCA means a common carotid artery, into the ICA, internal carotid artery, until it blocks the middle cerebral artery, which is the primary site where you can see in a left-hand side figure in a human, approximately 70% of the total stroke happens around this territory. I kept this occlusion for 2 hours. I re-anesthetized the animal to pull the filament out and establish the reperfusion. And this is exactly how that happens in hospital now, where the clinician retrieve the clot out by the clot retrieval technique and allow the artery to reperfuse. So a stroke model is most clinical relevant stroke model. Now, this is the method protocol for one animal. So 14 days before stroke surgery, all telemetry devices were implanted to gain the blood pressure, intracranial pressure, which is ICP, and the brain tissue oxygen signals. I will explain more about the telemetry implantation in next couple of slides. After surgery, animals tend to fully recover for 1 to 2 weeks. And 3 days before stroke surgery, I ran the behavioral protocol for consistent 3 days to train the animals with the behavioral test. On day 0, which is a stroke day, stroke was induced in all animals, and then again the behavioral protocol run on the day 1, day 3, day 7, and day 10, followed by the histological analysis. Now, for acquisition of the blood pressure and ICP signals, I used the dual pressure telemeter, as you can see on the bottom side of the picture. It has 2 catheters. So short length catheters were gently inserted into the abdominal aorta towards the heart to gain the blood pressure signals, as you can see in the topmost figure. Blood pressure catheter was secured with the Sergi mesh and glue in the abdominal cavity at the insertion point here. Now, oxygen telemeter was fixed in the abdomen along with the blood pressure telemeter. So as you can see, the blood pressure telemeter was fixed in the abdominal cavity, and that has short catheter and long catheter. And also the oxygen telemeters were fixed along with the blood pressure telemeter in the abdominal cavity to record the ICP and tissue oxygen signals. The long catheter, which is ICP or for ICP, and the oxygen electrodes were tunneled subcutaneously via hollow stainless steel rod to the skull, as you can see from the left side of the figure. Now, appropriately sized hole made into the red skull using the stereotaxic frame, which you can see on the left side of the figure. An ICP catheter was placed subdurally, as you can see here, and fixed with the Sergi mesh and glue, as you can see from the right side of the top, further right side of the figure. As you can see, this is Sergi mesh, and the glue was applied to fix the ICP catheter to gain the ICP signal subdurally. Then screw were placed first. So as you can see, these are the indication of the screws. Then auxiliary reference and the carbon patch electrode, which is CPE, were inserted and sealed into their respective sites with the dental cement, which you can see in the middle figure, which gives the stability and strength to the electrodes. So even animal moving in its cage, there is no chance that that can influence any signals of ICP and oxygen electrodes. Now, so this schematic shows the co-housing setup if the dual telemeters are used. The primary smart pad provides the wireless power to both implanted telemeters, and each smart pad transmits the data to the respective channels towards the computer into the Spike software. Moving towards the functional or behavioral setup. So animal were assessed for functional impairments pre-stroke and post-stroke on day 1, day 3, day 7, and day 10, as I mentioned earlier. There are two tests was used, mainly the sticky dot test and cylinder test. I'll give you a bit of introduction in the next slide for cylinder test. So the sticky dot test assesses the sensory motor functions and the time to remove the small adhesive patch, which is 1 centimeter square dot from the both forepaw into the 120 seconds was recorded and evaluated later. So that was test applied before and after stroke at certain point and to check what are the outcomes before and after strokes that was compared. Now the cylinder test measures the asymmetry into the limbs and also help us to evaluate the motor outcome before and after stroke. The animal was kept in a cylinder for 5-minute exploration and his paw movement was recorded and evaluated later, as you can see in the left side figure. So that was a setup in our lab for behavioral analysis. Now, yeah, I'll go back to Sam again to run the audience poll. Over to you, Sam.
Thank you, Pratik. Give Pratik a chance to catch his breath, and we'll launch the middle poll. So those who are interested in telemetry, perhaps are using telemetry. Is there a parameter that is most interest of you to capture while using telemetry? And with the options we have are ECG, EEG, EMG, blood pressure, sympathetic nerve activity, tissue oxygen, temperature, activity, optogenetic simulation, or none. While everyone is voting, I do encourage those to ask questions so we can get to them at the very end of the presentation. So just look out for that Q&A dialog box in the bottom below. You can ask any questions through the presentation. So it seems like the majority of those who are attending are interested in blood pressure, tissue oxygen, and temperature. 3 common known parameters. Okay, I'm gonna end this poll and I'm gonna bring back Pratik to continue his presentation.
Thank you so much, Sam. Yeah, so that was the previous part was all methods and introduction. Now moving towards the results section. Right, so this slide shows the raw data recording the showing all waveform signals while animal in its cage and moving freely. You can see on a y-axis that the blood pressure, heart rate, intracranial pressure, and tissue oxygen measurement in the Spike software. And later it was analyzed with the modified scripts to retrieve all the data. Now, this is a kind of interesting slide for me. So this figure shows the acute response to stroke shown in a 60 seconds of average data. And the left Y column contains the mean arterial pressure, intracranial pressure, and tissue oxygen before, during, and after stroke. Blue shaded area, as you can see, are presents like blue shaded area presents the anesthetic period. In this case, we used the isoflurane was the anesthetic agent. And the first anesthetic period is during the induction of the stroke. And second anesthetic period is when I remove the filament out and reperfuse the artery. The first dotted vertical red line, as you can see in your screen, that shows that exact time point where I induce a stroke, and the second dotted line or red vertical line where I remove the suture out. The exciting thing for this figure is that upon the 100% of oxygen during the anesthesia, um, tissue oxygen level increased. This is means like our oxygen signals and everything perfectly in place, and that was working very fine. And upon the occlusion of the middle cerebral artery, the tissue oxygen dropped below the baseline level, remain at the same level during the occlusion, and then upon the reperfusion, it returned to the baseline level. Now, regarding the blood pressure signals, during the first anesthetic period, blood pressure tends to fall due to the isoflurane, which is in line with the literature. Upon the conclusion of the MCA, blood pressure increase immediately, remain elevated during the occlusion above the baseline level, fall during the second phase of anesthesia, and then after reperfusion, it was still above the baseline level or pre-stroke baseline level around that maintained level. No difference was seen in the intracranial pressure before, during, and after stroke. Now, so to set up the possible clinical scenarios and hidden issues, as I mentioned in introduction, hypertensive rats were used for this study. These groups of animals were hypertensive. As you can see, the baseline pressure is above the of 140 millimeter mercury. The question we raised are, is preventing post-stroke hypertension to pre-stroke baseline level in the hypertensive rats detrimental? And the second main question that we raised is over controlling the post-stroke hypertension down to normotensive level in the hypertensive rats produce negative outcome? So there are mainly three groups designed in this study. So uncontrolled, where I did not give any treatment and left um, the post-stroke hypertension reached to the whatever the level that goes, and then when returned to the baseline level. Control group. So I used the labetalol to give the treatment to reduce the blood pressure towards pre-stroke baseline level, and I used the labetalol for 3 days to give a treatment within acute period of stroke. And the third group was over control group, which mimics the undiagnosed hypertension group as discussed previously, where I tried to reduce the blood pressure towards the normotensive level after stroke, and the labetalol also given in these animals. Now, this is first set of the results of our study. And as you can see in this results section, showing all physiological variables, mean arterial pressure, intracranial pressure, cerebral perfusion pressure, which was derived from MAP minus ICP, and the tissue oxygen level. This is daily average data until end of the protocol, which is day 9 after stroke, and the day 0 is the stroke induced day. As you can see, the vertical black dotted line. So in uncontrolled group, post-stroke blood pressure was increased along with the ICP, CPP, and tissue oxygen. However, tissue oxygen and perfusion pressure was not reached to the significant level above the baseline level. Now in the control group, so labetalol reduced the blood pressure um, towards pre-stroke baseline level. However, increased in the ICP during the acute stroke period, and that reduced the perfusion pressure below baseline level. And the tissue oxygen level was also elevated significantly above the baseline or pre-stroke baseline level during the treatment period, and which is the characteristic of the labetalol, which can preserve the cerebral blood flow despite reducing the blood pressure. Now in over control group, aggressive treatment was applied to reduce the blood pressure towards below pre-stroke baseline level or towards normotensive blood pressure level, and which increased the ICP, reduced the blood pressure, which increased the ICP, which caused a significant reduction into the perfusion pressure below baseline level. And we found a bit of variability into the tissue oxygen level, probably due to the anatomical variation in this group. Now this is functional or neurological data. As you can see in, in all stroke groups. So we found significant initial impairment in first few days after stroke in all stroke groups, but all animals were close to recovery at the end of the protocol, except over-controlled animals where initial significant impairment, which you can see in the red line, also noticed in ipsilateral side. Now, this is the histological analysis and survival analysis. So over control group showed the significant infarct volume and mortality compared to the uncontrolled group. So in summary of the first set of the experiments, when we target the blood pressure after stroke, treating towards pre-stroke baseline level may not be detrimental, but below baseline level or towards normotensive level may have a negative impact due to the hyperperfusion into the brain. Now moving towards the second set of experiments were designed on the research question that what happens while controlling the blood pressure after stroke in already treated spontaneously hypertensive rats before stroke. Hence, antihypertensive medication enalapril was given in the water for 28 days to hypertensive animals to keep the blood pressure at the normotensive level before inducing the stroke. After inducing the stroke, enalapril was continued in the same group like treated group, while additional treatment was given with labetalol for 3 days in control plus treated group. Here I'm just clarifying the name of the group. So treated term is used for the animals had inhalable treatment before stroke, and control term or control plus treated term is used for the enalapril and for animals had labetalol treatment for 3 days after stroke, including with the enalapril. Now in results section, showing daily average data of the mean arterial pressure, which is on the left hand side, and the brain tissue oxygen on the right hand side until end of the protocol. And the stroke was induced in a day zero. Again, similar was previously mentioned. So post-stroke blood pressure, you can see on the left-hand side, was again induced or post-stroke blood pressure increased on a stroke day, but was returned within 48 hours to the baseline level in the both groups. And in control plus treated group, the brain tissue oxygen was significantly increased in first 48 hours after stroke, which is again probably due to the labetalol characteristic, as I mentioned earlier, which preserves the cerebral blood flow despite reducing the blood pressure. Now, this is functional and neurological outcome. As you can see, the similar kind of result with the first set of experiments that regarding the both groups showed initial deficit after stroke, but showed a recovery pattern closer to the end of the experimental protocol. Right, and there's again histological and survival analysis, and I did not find any significant difference between the both groups while evaluating the infarct volume and mortality while analyzing the survival analysis. So, in summary of the second set of experiments, reducing the blood pressure after stroke, no difference were observed in infarct size and mortality in both chronically treated spontaneously hypertensive rats. Hence, no consistent evidence to suggest that preventing post-stroke hypertension in subjects already on antihypertensive medication is detrimental. Right. So overall conclusion draws that blood pressure increase immediately after stroke, regardless of the previous baseline, either hypertensive or animal treated with the chronic hypertensive medication. And in acute period of stroke, if we prevent the blood pressure to pre-stroke baseline level, is found relatively safe, while preventing blood pressure below pre-stroke baseline level or towards normotensive level, which produce detrimental outcomes. Hence, considering the undiagnosed hypertensive patients and treated hypertensive patients, middle ground approach is necessary while reducing the blood pressure after stroke to avoid any hyperperfusion in the brain and also to prevent a secondary complication such as like hemorrhage or other complications. I would like to pay a sincere gratitude to my supervisor, Dr. Fiona McBride, and Dr. Karen Barrett, and other lab colleagues for their guidance and great support, and funding bodies for their financial assistance. Right, so thank you for listening and really appreciate your valuable time. And I'm happy to answer your questions now.
Thank you, Pratik. That's a great presentation. And like Pratik said, we will begin the Q&A. So I will encourage everyone to stick around and ask as many questions as possible. We did get a few questions while you were presenting, so I'm going to get the ball rolling here, Pratik. First question we got is, were the telemeters checked after removal from the animal to ensure that they were still recording accurately? For example, any calibration checks or anything like that?
Right. So this is a great question. So yes, so each, like after I remove the telemetry or telemeters after once the protocol finish and euthanasia of animal, I have to check the offset of each telemeter. So in case in this study, I use the dual pressure telemeter. So I have to check the offset to be assessed prior to the each implantation to account for any drift in the pressure transducer over the time and with use. The offset is particularly important when considering a low pressure signal such as ICP. So that was a dual for the dual pressure catheter or telemeter. And for the oxygen electrodes, actually the carbon paste electrode were made separately every time and screened to ensure that their oxygen sensitivity was within the range which which need to measure the brain tissue oxygen. Now these electrodes again, once it passed the calibration check, then again reattached to the telemeters and calibrated in vitro after the attachment to the telemeters. And this calibration basically was to ensure that the sensing electrode would not saturate at the physiological brain tissue oxygen concentration, and also sufficiently sensitive to respond to any changes in a tissue oxygen I expect to see in vivo while I induce a stroke or after stroke period. Yeah, but for oxygen telemeter or for other detailed description, if you want to have then I urge you to attend the next webinar which specifically focus on a measurement of the tissue oxygen via telemetry. So that will be great to learn from there too. Yeah, thank you.
Oh, no problem. Great answer. The telemeters that you used, Pratik, were they single used or reused for your multiple experiments?
Right. So yeah, so telemeters were reused for multiple times, but the oxygen electrodes were, as I said, were replaced between the uses. So every time um, I actually make my own electrodes and pass the calibration, again reattach and pass the calibration and then use it. Yeah, but
Oh,
always check with the offset and drift. Anything that happens, then I'll have to check everything before implantation.
good advice. Good advice. How do you define the location of CPE in the stroke area?
Right, so that's a great question. So CPE means a carbon-based electrode. So um, MCA, which is middle cerebral artery, supplies the blood to the brain parenchyma of the primary motor and somatosensory cortical areas of the face and upper limbs. Now, we targeted to implant the CPE into the cortical penumbra area of the stroke. As you all know, maybe who are related or aware about the stroke, in fact, then you can see the core and penumbra. And in the penumbra area, which is exactly where the neural cells are still viable and are also in a reversible state. Um, so we targeted the area, and our lab colleagues has already defined and the predicted penumbra via surgical optimization and histology. So basically, we have established the perfect um, the dimension and the angles and everything for and the stereotaxically placement for implantation of CPE into the penumbra area of the stroke. Yeah.
Sounds like you guys have it down to a science. Um, so another question is, why was the oxygen variability found higher after stroke, even though you defined the place of CPE installment? And also, does this have an influence on the telemeter?
Right. That's a great question. Actually, I would say in terms of few multiple answers with this question that so all telemeters I used before implantation was calibrated. So all the telemeters were working perfectly fine before each implantation. And I believe that my stereotaxic placement of the oxygen sensing electrodes was accurate and consistent throughout each animal surgeries. And what I found is my baseline oxygen recording were generally similar between the subjects and groups. So, and all animals showed a similar fall in oxygen during the MCO, as I shown in a presentation. There was a one figure during the occlusion that was reduced after occluding the MCO or MCA. But I observed the large variability in the how the individual signals change in hours and days after reperfusion, which was unfortunate to see. But the high variability maybe in case in our study, maybe I can think of that may be due to the development of infarct volume or development of infarct core, and also because of the anatomical variation. And but probably which would be a good sign that in comparison, as we can see the how much disparity we can see or we can observe in individual patients in a clinical side where each individual are different even though they present the stroke. Yeah.
Okay, interesting, interesting. An attendee asks, Pratik, why did you use SHR over SHR-SP?
Yeah, I think that's most common question I get every time. Right. Firstly, the mortality ratio, I would have expected that must be higher in the SHRSP. And secondly, SHRSP do not show the right clinical situation where the young and hypertensive population has a different physiology. And as I mentioned, in New Zealand, that around 10% of the mortality that comes below 65 years of age. So yeah, and SHRSP has higher susceptibility to vascular permeability as well. So these are the cases we thought in previous, like before starting a study, but then I think we relatively choose the younger rats, and that's why we didn't choose the SHRSP over SHRs. Yeah.
That's a good reasoning. Why were two different antihypertensives chosen for pre versus post-stroke treatment?
Can you repeat it again? Sorry.
So the question was like that was asked was why were there two different antihypertensives chosen for pre versus the post-stroke treatment?
Right. Okay. Um, So what we have seen in a clinical stroke guidelines, which suggests that faster acting drugs in the acute period of stroke to control the blood pressure are recommended. And also the drugs which increases the cerebral blood flow or preserve cerebral blood flow, even though they're reducing the blood pressure, which is highly recommended. So the beta blockers like labetalol and the calcium channel blockers like nicardipine or nifedipine are most commonly used, which is highly recommended, and that's why we use the labetalol in the acute stroke or acute period of stroke. Now, chronic antihypertensive treatment, we choose the slower acting drug like ACE inhibitor, sorry, like enalapril, and which was preferred, and that's what we use to. We don't want the same drug pre-stroke and post-stroke, and that's why we choose the different drugs, but the clinically indicated drugs in the post-stroke and also the primary or the first-line therapy pre-stroke at pre-stroke level.
Okay,
Yeah.
interesting. No, good, good, good answer, good answer. Another attendee asks why 4 weeks of the treatment. So why 4 weeks of the treatment period? Why do you need 4 weeks for controlled SH rats? And also following up on that, what effect do you predict with a longer duration if you do longer than 4 weeks?
Right. So that's a great question. The intention behind to choose the 4 weeks of treatment because we did not want any influence that coming out from the pre-stroke level, which can influence any outcome on the post-stroke level. So that's why we choose the 4 weeks of treatment. Now, what we have seen in a literature and published studies that if um, the antihypertensive treatment that maintain more than 6 weeks or 8 weeks and longer than that, that may chance to remodeling or increase the chance of the remodeling of the blood vessels, which can impact or maybe improve or don't know worst outcome, but which can impact the resulting outcome at the post-stroke level, which we didn't want that. So yeah, we can do certainly later on in a future study, but that's why we just set up, like we just set it up that everything to reduce or to set up the blood pressure after stroke and influence and what are the outcome we get it. And that's why we didn't choose more than 4 weeks of treatment.
Okay,
Yeah.
that makes sense. This other question is quite interesting, actually, Pratik, is how do you see your study translating to real world stroke care?
Um, yeah, so that's a really interesting question, I think, and always I get it also when I give this presentation. So basically, certain things I would like to emphasize that I also included in study that the stroke model we use is basically highly clinical relevant stroke model. As I can see, and as I mentioned that nowadays from 2015, and all clinical side at the hospital, the all clinician use the clot retrieval technique to retrieve the clot out, and that's what we did. That we refurbish the artery, and that's what they do in hospitalization. And the FDA approved um, the extension of the clot retrieval technique for 24 hours, so which is very reasonable time when the patient is hospitalized and they can high chance to get the clot out. Now, as I mentioned earlier as well, that we addressed hidden and unaddressed issues also in our study. As I mentioned, the first one is poorly controlled or treated with antihypertensive treatment before stroke. That what happens if those patients already on antihypertensive medication for longer period of time, or even though with poor compliance, they don't taking, or they take or they don't take with the regular medication, um, and when they have a stroke, because they most likely have a stroke in future life, and if they have a stroke, um, which medication that can be used in the post-stroke period, whether the same medication that applied into the post-stroke period, whether additional treatment, as I mentioned in the second group of experiments, so additional treatment, whether that can apply or whether it can be used in a conjugated therapy in the post-stroke period, or any separate or third drug can be used. So that hasn't been answered yet. And even though not multiple, but the few clinical studies has been done in the past, and they also hasn't concluded any major conclusion. And the second I want to emphasize, which is highly clinical relevant, translating real world stroke care, is the undiagnosed hypertension. And as I mentioned, that proportional of the population in this category is quite high. And if you imagine the patient hospitalized with, sorry, I'm giving a bit brief,
No
big
worries.
answer.
Keep going. Keep going.
Yeah, but yeah. So, a patient hospitalized with the stroke, and imagine that patient hasn't been to the GP or clinic for longer period of time, maybe 8 months or 10 months or something, and because of stress level, their baseline of the blood pressure gone high, and that at the time of hospitalization, the clinician cannot identify the true pre-stroke baseline level, and this patient have a great chance to reduce their blood pressure below their true pre-stroke baseline level. So imagine what happens unintentionally, what happens to the outcome of the stroke, because that will also add more complication, adding to the stroke complications. So I think we imagine that will be dangerous for all those kind of patients, and that's why we see that this study has higher translating values to the real world stroke care. Yeah.
I agree.
So,
I agree with
uh,
you. Yes, yes,
thank you so
definitely.
much.
Your research will definitely be there for that real world and clinical future trials. Another attendee asks, in your research and that you presented in your experiments, how difficult is it to advance catheters to MCA from the abdominal aorta? And how do you know if you're the right MCA, since it's a long way to travel with many cross branches?
Sorry, I think okay. So how difficult is the advanced catheters ICA?
I think
It's MCA, I think. Oh yeah, so it's written in there. So from
yes.
abdominal aorta. So we don't. So MCA is middle cerebral artery, which is in the brain, and we didn't put any. So not catheter, but the filament we put in MCA. Um, and how long we had to travel many cross branches, right? So So there's this I was familiar with the surgery because I in my master's study also I used the stroke model, a similar stroke model in India in one of the company, and also the same model I use here. But then to identify this filament, so basically when you are in a surgical space, and then um, when you insert the filament in from the CCA into the ICA, which is easy to check the bifurcation, um, from the common carotid artery, where there is a two bifurcation, like bifurcation happens into the internal carotid artery and external carotid artery. And basically, I just want to clarify here that abdominal aorta, which is downstream to the lower limb, um, further downstream to the heart. So the abdominal aorta, which is the point where I use the catheter to get the blood pressure signal, which is different surgery to the stroke surgery, which is MCA. So implantation surgery happened 14 days before stroke surgery. So there were two surgery before implantation and stroke. So I'm just telling about the stroke surgery now. So as you identify the bifurcation in MCA, you insert the filament into from the CCA, which is common carotid, into the ICA, and there are multiple branches for the ICA. But you advance the filament, the direction. So I did the sorry, I forgot to mention that I did the unilateral or one side, left hand side MCA. So when you advance the filament, after 22 or 23 millimeter advancement of the filament, you feel the resistance. And when you feel the resistance, then that's a kind of a point where you occluded the MCA, which comes with the practice. And when I feel the resistance, then I feel that this is the right place and I'm occluding the MCA. And then I tied that artery with the filament and kept the occlusion for 2 hours. And again, they reopen the artery and then remove the suture and then glue it up the artery, and which established the reperfusion. So that's kind of a procedure with occlusion and reperfusion. Yeah.
Thank you for taking us through that process. It's quite interesting. There was a couple questions based on your research specifically. I don't know if you see them, Pratik.
Um,
One of them was talking about the beta blocker. Sorry, Pratik.
yeah, you go for it.
No, as they were mentioning the beta blocker you used in the antihypertensive drug in a certain setting, and they were just wondering about more information about that.
Right. Yeah. As I mentioned that clinically, like the stroke guidelines, or the stroke guidelines, they do suggest a certain drug, as I said, like a faster acting drug, and also the drugs uh, which should be used that preserve the cerebral blood flow, because a stroke is the basically that reduction of the blood flow to the certain part of the brain, which deprives oxygen and nutrients. So if something or the drugs which help in this scenario, that will be highly recommended. So, and that's why we use the beta blocker, and levodopa has a characteristic which can be used an antihypertensive drug in this scenario, and that's why we selected this drug. Yeah.
Okay. Based on your graphs, one of the attendees is also asking how some of those units are converted. So from PO2 to some of the other real units or pressure units. Can you talk a little bit more about that, or?
Yeah, so I think that's very technical question, but I can give a brief answer. So the recording we get in nanoampere, and that's basically how the telemetry and the signal designed to get the nanoampere signals into the computer output in a Spike software. But according to our need, that was converted into the micromolar. But as the next seminar or webinar is happening on the oxygen telemeter specifically, then definitely um, the technical specialist in the next webinar will cover this question in detail, to how to convert these units to get the proper identical signals. Yeah.
That's true. Thank you for mentioning that. So yes, if you'd like to know more information about that type of measurement and parameter, next will be the webinar for you. I have another question for you, Pratik. I know your study is on hypertensive rats. Is there another animal model or maybe perhaps a knockout or knock-in model you'd like to perhaps in the future do these same studies in?
Um, we haven't decided yet that use a knockout model yet, uh, but probably what we are doing right now and what we're thinking to develop a further understanding into the blood flow, that that how we can measure the direct and real-time blood flow, what happens when we use Telemeter or different drug um, during that time, or maybe the age and maybe the gender, or yeah. So this and the timing of the when we start the treatment. So these are multiple questions we are thinking to start with. So these are the things that we are working on at the moment to establish our methodology, and probably working on a future study, but haven't think about any thing at the moment in a knockout model. Maybe in the future, maybe markers or something that we identify something, and then we can do and we can propose, but not at this stage. Yeah.
Okay, well, there's always that for the future, but it is nice that you can recreate some of these experiments and some of these models that you've done in future studies.
Hmm.
Um, it appears that I think if anyone has more questions, please send them in. But I think we have covered almost all the questions. So I am going to thank Pratik for his presentation, and we are going to end just a few minutes early. So again, thank you all for attending today's presentation. As mentioned earlier, we will, if you have any other questions, we will get to them at a later time, and we will publish all the answers and questions from today's session and make them available to everyone. Again, I'd like to thank Pratik for his insightful talk. I'm hopeful that everyone walked away satisfied that we met their learning objectives as Pratik discussed the measurement of tissue oxygen, intracranial pressure, and blood pressure by telemetry in a rat model of stroke. How does pre and post-stroke treatment of hypertension affect post-stroke outcomes, and the benefits and challenges of performing telemetry measurements and considerations for experimental design. Again, please feel free to reach out to us directly or to Pratik with any questions you had about his presentation. And as Pratik mentioned, I'd like to remind everyone to register for next week's presentation titled Introduction to Measurement of Tissue Oxygen in Rats via Telemetry, where we will expand on some of the topics that Pratik touched on today. This will be on November 11th, 2020, where Dr. Sarah Jane Guild, who is the Chief Scientific person in Sciences, will discuss, amongst other things, how a carbon paste electrodes used to measure tissue oxygen, calibration and preparation of tissue oxygen telemeters, and combining tissue oxygen measurements with pressure and or biopotential signals. Thanks again to everyone for taking the time out of your day to attend our session. We look forward to seeing you at one of our upcoming events. Hope everyone has a great day. Bye. Take care.